Hello everyone, here is Dr. Harim Jaffer. This is our fourth lecture in the series of our lectures in the University of Sulaimani, 5th class, 2020. My subject today is about gingivectomy and gingivoplasty. I'll take you through a series of topics. We will talk about the condition in brief, then the instruments, surgical steps, healing, instructions, and finally I'll show you a YouTube video of my surgical operations of gingivectomy and osteoplasty also, so you can get benefit from the clinical case also. So we are starting in brief in definition of gingivectomy. Simply, it's the excision of part of the pocket wall to provide the visibility and accessibility, and to get a visible area for cleaning and root detoxification. So briefly, the excision of that part of pocket wall to get accessibility and visibility is named gingivectomy. As you see it here, for example, there's a lot of swellings and pseudo pockets, and part of the tooth are buried under the gingiva. So we need to excise the excess pocket wall or pseudo pocket wall to get access to the full length of the crown and get root surface detoxification, and make a room for a good oral hygiene measures like brushing and flossing to be done properly on daily basis. Regarding the indications, the indication of gingivectomy are elimination of the periodontal pocket, but not a true pocket, a pseudo pocket, elimination of gingival enlargement, suprabony defects which needs access to restorative treatment, and asymmetrical or anesthetic gingival topography. Here, this is a case of that needing a gingivectomy which have a pseudo pocket. We need to remove the excess swelled gingiva, and here without bone loss, it is just the gingival overgrowth. And as you see here, an aesthetic gingival topography, an evenly distributed contour of the teeth. For example, the central is here, that one is here, this lateral is here. So uneven or anesthetic contour. Also, the suprabony pockets. Usually the gingival pocket is the formation of a pocket without bone loss, as we said here, pseudo pocket. While periodontal pocket, one of the periodontal pockets, we can do the gingivectomy if it was suprabony pocket. In suprabony pocket, we have bone loss, but the base of the pocket is higher than the bone loss area. So it is it's above the bony defect. This is the bony defect, this is the bone loss, and here the base of the pocket is above the bone loss. So it is suprabony pocket or suprabony defects. So in this case, we can do gingivectomy if we have gingival overgrowth and we need to access the root surface or the tooth surface. But in case of when the periodontal pocket is below the dissect the defected bone, as we see here. This is the base of the pocket, and we have a bone loss. So in this case, we can't do gingivectomy because we may expose the bone surface and end up with necrosis. So this is the indication. The contraindications are the presence of intra-bony pocket, as we talked about, or when the pocket extending beyond the mucogingival junction, or when we have a minimum attached gingiva, or in cases of severely inflamed tissue. For example, this is the infra-bony pocket, as we talked about, and here, as you see, we don't have an attached gingiva. In this case, we can't do gingivectomy for any cases. For example, and here, this is recession. For example, here, this is a minimum amount of gingiva. We can't do gingivectomy on these cases. Or in cases of severely inflamed tissue, in cases of inflammation, because we need to do, for example, a mechanical treatment, and then if it's needed, a chemical one also. So we should wait for the healing process to be done. Then after that, when the gingival recede and the healing process completed, then we decide that this case need a gingivectomy or not. But in cases of inflammation, we shouldn't decide on any cases of gingivectomy. This is in brief a definition, indication, and contraindications. You have many instruments that are used for performing a gingivectomy. One of them is laser. I didn't mention it here, but the main instrument, we can use a blade usually. Nowadays we are using the handle Parker handle number 3 and the blade number 15 to perform the gingivectomy. But the basic instrument is the periodontal knives, like Kirkland knives, are used for incision on facial and lingual surfaces. The design is just fitted for this procedure. You have an angulation on the working end, which can easily perform the 45-degree cutting on the gingival surface. This is the Kirkland, and this is the Orban periodontal knife. This is a supplemental knife used for incision of the interdental areas to just loosen or cut the periodontal papillary area when you cut through the gingiva. As I said, the blade number 12 and 15, mostly we use 15 because it's more accurate, and you can stabilize it very well because the head are smaller. You put all the power here for cutting the gingiva, and beside that we can use a burr, a tapered large head round burr. This is used for reshaping the gingiva after that, not for cutting the tissue. For reshaping the gingiva and making a slope in the new free gingival area, or new gingival neck or sulcus, we are using for reshaping the gingiva, we use a large tapered round burr. And of course we are using lasers, but we didn't mention it here. Surgical steps. Simply, the surgical steps. First is the marking process. After you anesthetize the area, you should anesthetize the area. Then you should mark the pocket by a pocket marker or a periodontal probe or anything making a marking of the area to be excised. So the first step is the pocket on each surface are explored with a periodontal probe and marked with a periodontal marker to form a series of small bleeding points. Each pocket is marked in several areas to outline its course and each surface. So you should draw a map. That map will guide you throughout the incision. This is the first step. The second step, the incision should be made at 45 degrees in the lower and in the upper also, like how you do a brushing. So the third step, the excess part, when you do an incision, the excess part is excised and it's removed. The other step is subgingival area is curated. It should be curated to remove any excess or bacterial debridement. We are doing the bacterial debridement, and we cleaning the area from any, or we detoxify the area from any bacterial aggregation. The last step is surgical pack is placed, which is optional. Sometimes you use it and sometimes you don't use it, according to the case and the wish of the patient. Regarding the healing scheme, we have 4 healing process. We have first of all bleeding, then it will become a scrub, cases of inflammation, then proliferation of the fibroblasts, then remodeling. The first step starting from the clot, and the clot is then replaced by granulation tissue within 24 hours. Then inflammation, the highly vascular granulation tissue grows coronally, creating a new free gingival margin and sulcus. Then the proliferation, the epithelial activity at the margin reaches a peak in 24 to 36 hours, and surface epithelialization is generally complete after 5 to 14 days. Also, complete epithelial repair takes about 1 month. And remodeling occur and complete repair of connective tissue takes about 7 weeks, nearly 1 month and a half. So complete healing process to gain a complete gingival reconstruction, it takes 7 weeks. This is regarding the healing scheme. While the instructions, post-surgical instructions, you should gently floss the area. You can gently floss the area without touching the stitches if there's stitches, and without touching the size of excision or surgical parts. Second, the treated area could remain tender up to 1 week. So you may face a pain for 1 week or a discomfort for 1 week, but we have also something named delayed discomfort. The delayed discomfort is that in the first week you have nothing, or you experience a little pain and swelling or tenderness, while in the second week you may face a large amount of pain and discomfort, which may surprise the patient and feel something odd about the surgical operation. But you should reassure your patient because this will happen in some cases. Avoid hot temperature foods. Avoid crunchy, spicy, and salty foods. Chew on the other side of surgery. Soft food is desired for the first 3 days. Some medications can increase the amount of bleeding, such as aspirin, Plavix, Coumadin. If the area continues to bleed with the gauze in place, remove the gauze and replace with a moist, small tea bag. The tannic acid in the tea will help to control the bleeding. Sutures may or may not have been placed, as we talked about. If sutures are in place, they are resorbable and will come out within 5 to 10 days. And they may untie and become loose. So do not attempt to pull or remove the sutures. If they are long and bothersome, you can trim with a small scissors. It is best not to return to work the day of the treatment, because you have some discomfort and some oozes of bleeding, so it's preferable to take a 1-day rest. Avoid exercise or heavy lifting for 2 days. It's best not to smoke during the first week, because the smoking, as you know, it will delay the healing, so it's avoidable. If a prescription mouth rinse has been prescribed, rinse twice daily, after breakfast and before bedtime for 1 week. Don't overextend the mouthwash. Most of the times we are just using the mouthwash just in case we can't brush properly in that area, and maximum we are using it for 10 days, and after that it should stop for daily uses. Pain medications take as needed, like ibuprofen, Tylenol, Advil, or prescribed medications, like Profen, for example. An appointment will be scheduled for you to return 7 to 10 days following the surgery to evaluate the healing of the treated areas. So these are the instructions, and in the summary here I put it a video for you, just to see the procedure clinically and to get benefit from a clinical surgical procedure of gingivectomy and gingivoplasty. Actually, gingivoplasty is the reshaping process. It's a recontouring process, while gingivectomy is the cutting or excising process. So as we see here, we have it, for example, the anesthesia here. You can watch the video. This video is present on my account, Tutorial Jafar Rashid, YouTube. So you can watch the whole video there and get benefit from the surgical steps. This is the marking process. We don't have a pocket marker, but simply we can use a probe or sometimes an explorer to mark the area, as you can see it after that. As you see the points, these are your maps to excise the area. We mute it for you to hear my voice, and this is the incision or the excision. The incision is the process of using the blade for cutting, while the excision is the removal of the incised part. As you see my hand, it's like in 45 degrees. Like that. And I usually sometimes approach a different technique for gingivectomy. Here, after excision, as we see here, after excision of the incised part, these parts, we marked it and incise it, then we excise it. After removal of these parts, we just elevate the flap. Why? In some cases, we need osteoplasty. We need to perform or to create a new bed for the gingival tissue to rest on, because sometimes you have a possibility of gingival overgrowth again. If we have the same embedding, it's the same bone or the same bony contour beneath the gingiva, it may overgrowth again. But if we create a new place for the gingiva to set on by, and this is the detoxification of the root surface and the neck of the tooth. So sometimes, in order to avoid the regrowth or gingival overgrowth or relapse of the case, we just do osteoplasty, do a recontouring, as you see it here with a large round bear, tapered round bear, and we festooning the periodontal, the papillary area, in order to place the gingiva on a new position that it difficultly will return back to previous condition. So this is the case, and actually this case needed a PRF. I hope you enjoyed the case and the lecture, and thank you for listening. This is not within your scope, that's why I'm not going to explain it for you. Thank you, and thank you for listening.